And welcome to Duke Spine Institute. We're streaming live spine surgery today. This is case number 3 of the day. Our patient is from Kentucky. It is Thursday, May 8, 2025. And he has a herniated disc at L5-S1. He has predominantly leg symptoms on the left side. So we're going to do surgery to unpinch the nerve, L5-S1, left side. All right, I'm going to go ahead and get started. And most of the patients with disc problems, they don't just have leg symptoms, but they also have back pain. And the back pain from a disc at L5-S1, that back pain is going to be localized to the L5-S1 area, so right here. Now he has a tear in the wall, which has allowed the jelly to escape. And now there's a herniation. The nerves that come down and go down the leg are being pinched by that herniation. So I'm going to go ahead and put some numbing medicine in and see if we can't get this case started. Is he ready, Dr. B? Whoa. He's ready to wiggle and twist. If you have questions, feel free to ask. Our patient is going to be under anesthesia, asleep, but this is local anesthesia done with propofol sedation. I have to find the right spot to enter to get to L5-S1. I'm going to use the X-ray machine to help guide. All right, looking good so far. Is that his arm moving?
Arm over here, Hector. Left side. Thank you.
Well, let's get that arm back in position. Just lay still, you're doing great. We're putting you to sleep. Any questions?
At this moment, no current questions.
Well, let's start by showing our audience that 30 different things that cause back pain.
Of course.
Shot. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. And welcome back. You can see from our animation, there are 30 specific, distinct structures in the back that will cause back pain that can last more than 6 weeks. As a matter of fact, a lifetime for most of them. The disc is the number one cause of back pain, disc injuries to be specific, and the injury must happen in the back of the disc. It's called a posterior annular tear. It's a tear in the wall of the disc that allows the soft jelly in the inside to squeeze out, much like a jelly donut. If you take a jelly donut and you squeeze it, the jelly will squeeze out through that little hole in the wall. And the jelly that's squeezing out and stuck in the hole or just outside is what's causing his symptoms. There's one surgery in the world that addresses this, and that is the surgery he's having today. Now, he had to travel to Florida from Kentucky to get this surgery. He doesn't live in Florida. We call this traveling for medical care, medical tourism. And Duke Spine Institute is probably the top destination in the United States for back surgery because we perform the most advanced surgeries in the world right here in Florida for people from all around the world. Now, I have to say Germany is probably the number one choice for most people, but our surgeries are better and safer and more effective than the ones done in Germany. The Germans are still doing old surgeries like artificial disc. Who wants a big piece of metal in your back? I don't. And Americans are traveling to Germany to get artificial disc put in. You don't want that, folks. That's bad. Anything foreign in your spine is going to change your spine's function. It's going to change the way your spine works. It's going to cause new problems that you didn't have before in many cases. So this surgery you're watching does not put anything new into your spine. We're just helping your spine repair itself by removing the herniation and scar tissue around it. That gets rid of the back pain. It allows your body to heal the disc itself without any kind of biologics or implants. Henry, do we have any questions?
Yes, we do. This question is coming from Frank on YouTube.
Welcome back, Frank. It's been, what, a day?
1 or 2 days, asking Dr. Duke, if I have numbness and pain in both legs, but worse in the right leg, and also lower back extreme pain when I stand up, is it possible I have a rupture on both sides on my disc?
It is possible, though it's not necessarily the case. Frank, I need to do an examination. With my exam, I'll tell you what's causing your symptoms. Until you get that diagnostic Duke spine exam, everything we're doing is speculating. All right? That would be like speculating that if you hear a fire engine coming down the street, you're speculating that it's coming to your location. Well, it could be going somewhere else. So it's important that if your house is on fire, it's coming to your house. So it doesn't mean every fire engine is coming to your house. So we have to make a diagnosis. We have to find out, where is your pain in your back? Where is your leg symptoms? Where are they coming from? If you only have a disc problem, then yes, it's safe to say that the disc has herniated on both sides and you need surgery on both sides. But if you have a disc problem and a piriformis problem, like so many people, your disc could be causing one side pain in your leg and your piriformis could be causing the other, or a facet. So if you watch the video we just played, you can see the disc is the most common cause of back pain and leg symptoms, but it's not the only cause. Facet joint injuries and facet joint arthritis is the second most common cause of back and leg symptoms. All right, this patient has a pretty good size herniation at L5-S1, and his biggest problem is pinched nerve. Like I tell every patient, we're never going to make your disc look normal. People ask if we should get an MRI afterwards. The answer is no, it's a waste of time. But what matters is, how do you feel as a patient? How do we feel after the surgery? Did we get rid of your symptoms? Are you back to feeling normal? If the answer is yes, then we've done our job. No doctor is ever going to get rid of the entire herniation, ever. It's not possible. All right, so here we are, and I'm going to try now to move more medially towards the medial part of the herniation. So the herniation has two parts. It has a part that's towards the lateral side, towards where I am, and it has a part of it that's medial, towards the midline. I've just started working on the medial component. You can see some of that herniation right there. It's blue. By the way, our first patient, who had 4 levels done, he's already gone. And our second patient, she had 2 levels done. She's getting ready to go. Both of them doing very well. Any questions?
We have a comment coming from Frank once more on YouTube, saying, I watch you all the time. Like I said, I've watched at least 100 of your surgeries already. I'm getting ready to send you the MRIs. I'm just trying to get a new MRI of my neck also.
Sounds good. Well, just so you understand, Frank, we only can do one body part at a time. So I would recommend you get your one MRI in and get one telemedicine scheduled. And then once that's done, or even in the process, we can do your second MRI review. At least get it scheduled, okay? Watch the tube. Appreciate the confidence you have in our work. We are unique. We offer the very best treatments in the world. There are other treatments available to patients like you, but they're far more invasive and less successful.
We have another comment coming from Frank, once more on YouTube,
Sure.
saying, I want you to review my neck. I'm the one that had the ACDF on there already.
Yeah.
I want you to review it because I'm still having a lot of problems in my neck.
Yeah.
I don't think the orthopedic surgeon was good.
Yeah, I'm going to review your neck too, but the way we work here at Duke Spine, everybody gets a free MRI review that wants one, which you want one, and we don't do everything at the same time. So you're going to have to set up a second MRI review afterwards. Just decide which you want done first. But we don't just do every body part MRI review at one time for free. That's not how it works. So you will have to choose which one you want done first, your neck or your back.
And at this moment, no current questions.
In that case, let's show our audience how we fix disc injuries like this one.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A quarter-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Well, we just got word that the Vatican has announced the Pope to succeed Pope Francis. And apparently, huh? Well, then I won't mention it. But we've heard that there's an announcement. But you know what? In the day of fake news,
Here it is. It says it also on their accounts,
Fox News. Well, if it says it on Fox, then it's real. So the new Pope is an American Pope. It's an American cardinal. Is that correct? Berndes? He's now accepting PayPal. All right, never mind. We don't know if there's a new pope or not. That sounds like, doesn't sound right. And maybe somebody out there knows. Has the Vatican chosen?
This is from NPR at 1:24 p.m., so 14 minutes ago. A senior Vatican official announced a new pope's name in Latin from the balcony of St. Peter's Basilica is Cardinal Robert Prevost, an American from Chicago.
Wow. That's amazing. An American.
Cardinal Robert Prevost.
Well, congratulations. All right, so far everything is going really, really good. Right? They circulated a DocuSign. All right, there we go.
Yeah, he just began his papacy.
That's amazing. So, great to hear. Any questions?
No current questions, but we do have a comment coming from Frank once more on YouTube saying, by the way, I went to University of Florida also. I used to jog my Shands Hospital every night. I was there in 1987 and 88. Emmett Smith was a freshman when I was there, and Kerwin Ball was the quarterback.
Wow, that is pretty cool. I was at the University of Florida in 97 to 2024.
Oh, we just got a question, another question coming from Hira on YouTube.
Hello, Kira.
Hira asks, how...
Hold on a second.
Yeah,
Let's get Grabzilla. Go ahead.
Hira asks, how much herniated disc should be removed? Only the herniated part, or can we go further? If further, is it up to the anterior longitudinal ligament?
Yeah, it's a great question, Kira. Thanks for asking. So when you remove a herniated disc, you want to try to get 100%, but there's no surgeon on earth that gets 100%. We all do somewhere between to get a good result, 50 and 80%. That's my typical result, 50 to 80. I have never had a failed surgery where I didn't get rid of the patient's symptoms. And I think the worst I've ever done is probably somewhere around 50%. So your goal is to get as much as you can, but you're limited by some of the anatomical structures. So you can't get everything. You're limited by the facet, by the lamina, by a bunch of other things. In this case, the iliac crest, bone, and the nerves. So we're trying our best to get as much as we can. I think we got a pretty good bite there. That was okay, mostly scar tissue and herniation. But as I said before, this process is a debulking. What does debulking mean? It means you're taking mass out of the herniation. You're removing it little bit at a time. You're cleaning up the tissue that makes up the herniation, which is mostly herniation, but it's also scar tissue. So I'm removing scar tissue and herniation, both. And the reason why there's scar tissue is his body's response to the herniation. I got about 5 minutes. His body's response to the herniation is to attack it with the inflammatory system, make it go away, destroy it. And unfortunately, that doesn't work. What happens instead is the scar tissue that's created is new mass. So it adds to the herniation that's already there. And the two of them combine to make even more pressure on the nerve. So over time, more herniations come out, more fragments are released through the tear, and there's more inflammation and more scar tissue. I'm going to try another grab with Grabzilla. But this is the herniation right here. You're seeing it. It's like imagine somebody does a chin-up, right? And you go and you look at them on a chin-up, and you can't really see their head or their shoulders. You can see their waist and their feet. Like their head and shoulders are up higher, hidden. So that's what's hidden up there, is the head and shoulders of the herniation. What I'm taking out here is the feet and the waist. And as I do this, remove this herniation here, more of the head and shoulders come down lower. So I may be getting the waist right now, but later on I'll get the abdomen and the chest cavity. You guys see what I'm talking about?
Yes, we do.
All right, I'm going to try to get in there again. Wait, let me see if I can take a little more of this tissue. There's a little bit of fat right here, a little bit of what's called foraminal ligament. right there. And I'm just going to have to zap a little bit of that fat and foraminal ligament away to get more of the head of the herniation. Now at the 12 o'clock position, that's where the head of the herniation is, the top of the herniation, the tip of the iceberg sticking up. And that's what's pinching the nerve. So the more I could take away of the body of this herniation, the less pressure there is on the nerve, which is really at 12 o'clock, but outside the tube. All right? Hopefully that makes sense to you guys. That's a pretty good piece. Not really that big, but. Now removing the tumor, like the herniation, a little bit at a time it's called piecemeal, and it is a very common technique in surgery. Surgeons remove things like herniations or tumors piecemeal, meaning a little part at a time, because the whole thing won't come out. The whole herniation, unfortunately, is scarred. It's scarred down to the surrounding bones and ligaments. So I've got to remove it a little bit at a time. All right, let's go with Grabzilla. Don't touch the tube, I'll handle the tube. Any questions?
No current questions, but we do have a comment coming from Frank once more on YouTube. Just for coming back from the Pope, saying that's the first American Pope ever. Thank God.
Yeah. Well, I know it's a tough job figuring out who to make the Pope. So it's kind of cool that it's an American for the first time.
Actually, I was just watching the movie Conclave.
Yeah, I watched Conclave too. Very, very interesting movie.
One of my favorite films of last year.
You fell asleep? You did? Yeah, it's a bit of a weird movie, but... Huh? I thought it was a good movie, but the end was kind of interesting. Not really what I expected, but... I imagine it probably offended a lot of Catholics.
There was notes saying that the actual conclave for the electing the new pope now used
2
that
minutes.
movie to use as reference.
Really?
Yeah, that's what I was told. I don't know if it's true or not, but I loved that film. That was one of my favorites last year.
Gorge?
Oh, that's Apple TV movie.
All right, guys. Well, I've gotten about as much as I can get of this herniation. I'm going to take one more look in just a second here. I'm going to take a little bit more of the fat. This fat is sitting in there right around the nerve root. And the fat is used by the nerve root, by the way, to produce energy for neural transmission, sending signals. Let me see the grabber. Neural transmission or sending signals along nerves is very energy intensive. It takes a lot of energy.
You have a video that shows the cross section and the sagittal section of the disc.
Yeah.
Here's the hoses. Do you show those? Or do you show those?
You mean like on an MRI?
Yeah, what it looks like.
What the herniation looks like? Yeah, you can see it. I could show it to you, or...
No, I was just saying on your I didn't see it on the website. Anatomy of disc.
Yeah. We do have a lot of animations showing discs. Let's see what's left here. Try one more time with the laser and we're done. I think I've gotten about 55-60% of this herniation. I'm allowing it to move away from the nerve and sink back down towards the disc. Unfortunately, there was no giant piece that came out. We like to see giant pieces. But sometimes that just doesn't happen. And in this case, that's not going to happen. All right, we're pretty much done. Let me just take one more grab. But I think we've gotten as much out as we can. And there should be really good pressure relief off of that nerve. These are little fragments of herniation. They're thin little wisps. God damn it.
We have another question
That's about it. I'll take it.
coming from Hira once more on YouTube, asking, can a calcified disc at level of the dorsal spine can be removed via this procedure?
Can a calcified disc be removed? So every disc herniation has some calcium. And I would say 99.5% of disc herniations with calcium can be removed with this technique. But the top 0.5% are calcified herniations that are solid, like rocks. And those cannot be removed with this procedure. As a matter of fact, I'm not sure if there's any procedure that can remove those. But thank God I never see those. I've not seen a calcified disc here in the back in the last 29 years that I could not remove with this procedure. So I don't think it exists, but in theory it exists. But in reality it doesn't exist. So in theory it exists, but in reality it does not exist. Does that make sense? So every single disc herniation has some calcification in it. But only a solidly calcified disc herniation cannot be repaired with this surgery. All right, we're done. Again, we probably got 55-60% of the herniation, which is more than enough to get the pressure off the nerve. Now, nerves take time to heal. They take about a year to fully heal. I can't speed that up, but they grow back at about 1.4 millimeters per day. Thank you. And it just takes time for those nerves to heal. So he may have numbness after surgery that takes a year to go away, but I expect his strength to be better tomorrow when I see him. And the leg pain should be pretty much gone. Some patients, about 5% or less, will have some leg pain the next day, and that's just the nerve healing. All right, any questions?
At this moment, no current questions.
We're done. We got one more case to go. Thanks for joining us.